Good morning and happy Sunday to all the attendees who have joined from the different parts of the globe. And today, the first free webinar on biostatistics. And I am Dr. Tapas Kumar Sahu, the course director, as well as one of the core faculties of 360 Critical Care. Before going into the details, many of the people, many of the attendees might be thinking, who are we, why we have started this type of initiative just before 1 month of 2025. So it's not that we are starting this initiative, we are here in this I would say domain, in this initiative where we are trying the critical care trainees across the globe to clear many of the exams in critical care. And out of that, the prominent ones are European Diploma of Intensive Care 1 and 2, that is EDIC 1 and EDIC 2. Then the Indian National Exam, DRNB, as well as DM Critical Care. And there are also other societies like Indian Society of Critical Care Medicine, which is the apex society of critical care in India, very reputed one, ISCCM, and under the aegis of ISCCM, IDCCM, we are also having the IDCCM course, and this is all online, and we are also having on-site courses, and there are few of the courses are coming to help you in the practical exam for the DRNB and DM, and we are having the first one in Bangalore, India, in the month of January, towards the end or February mid. We have not finalized the date, but it will be definitely before your practical exam. So the first one will be of the high standard, where we will be having not only the practical sessions, rather the cognitive sessions, how to click in your practical exam, in your Viva exam, how to read the examiner's mind, and how to answer smartly, how to get the clues from the examiner's small clinical vignettes or some of the hints. So everything would be discussed in that. So before that, the concept of this webinar, which we thought about last 3 months back, is due to the feedback from our different course attendees that biostatistics is one of the horrifying feeling, and whenever the exam comes, they start to think about how to read that biostatistics, which they have never read, or they have not given that type of importance in their training period. So that is something which horrified them, and that's the reason people have shared their feedback that they need help with the biostatistics. That is point number one. And the second one, that is the basic sciences. So that was the two feedback which propelled us to think about something which have never been attempted in at the national level, at the global level. And that the theme in which we thought about starting our the first class, and that has to be again made free for everybody. So we have our regular ongoing courses, but we thought apart from our course structure, we will be adding something not for our own course attendees, but also there are many people who are not able to join our courses. So this is something which is very unique, and the first class is today, and I am the opening batsman. So without further delay, the learning objective of my class, which is 1 hour of class around. So we will be trying to understand the core biostatistics concepts for the exams. We'll be analyzing the statistical parameters with practical exams. Believe me, I will try to give you so much of examples that you will be fed up with that. Okay, please, sir, let's not again discuss biostatistics till the exam. So maybe you will be writing these questions in your exam paper directly without reading again. Now, the third one would be to simplify the risk assessment with proper intuitive explanations, and definitely I would try to enhance your exam readiness with high yield strategies. Now, the first part of our biostatistics is to unraveling the mystery of prevalence and incidence. What is prevalence and what is incidence? So this is something like the two terms which are often used in epidemiology and public health to measure the occurrence of diseases, because we are all like the clinicians, so definitely we want to also know why the diseases happen and why the complications due to diseases will be also happening. And that's the reason why as the biostatisticians or the responsible physicians, we need to know these type of the epidemiology concept. Now if we'll be trying to go one by one, what is incidence? Incidence is the rate of new cases of a disease that develop within a defined time period, and it provides insight into the risk of developing the disease. So it's not getting the number only, rather also what are the risks that would be associated with the development of the disease. Now the third point would be it will be also useful in studying the cause and the risk factors associated with the disease. So these are the three things that need to be understood. Now on the same side, if you will be also going into the detail about the prevalence, it represents the proportion of individuals in a population who have a specific disease at a specific point in time. So the time factor will be there in the prevalence. Now it reflects, the second point is very important, which is the differentiating point from the incidence. It reflects both the existing as well as the new cases of the disease. I have enough examples, so let's try to go one by one. Now, the prevalence, the importance is it helps in understanding the overall burden of the disease in a population. So what is the current, the burden status of that disease in the current scenario in a defined population? So this is the basic difference. And then again, moving forward, let's try to know the key difference between the incidence and prevalence. Now, incidence measures the rate of occurrence of new cases. New is the point for the incidence, offering information about risk of developing the disease. I think the statements are very clear to understand. Now, prevalence measures the proportion of the population affected by that disease at a given time, indicating how widespread that disease is. Now, in the incidence, there are two terminologies sometimes you will be getting in your biostatistics. One is incidence rate. Incident rate is the number of new cases occurring during a specific time period. Now, the cumulative incidence is another terminology, is the proportion of a population that develops the condition over a set period. So incidence rate, cumulative incidence. Now, on the other hand, prevalence, their terminologies are point prevalence. Point prevalence is the proportion of a population with a condition at a single point in time. So at that point, what is the number of patients or number of persons affected with that disease? That is the point prevalence. There is another terminology which is the period prevalence, and period prevalence is the proportion of a population with a condition at any time over a specific period. So if it will be for 1 month, 6 months, 1 year or so. So this is a period, but point would be at a single point in the time. Now, in short, the definition of incidence: new cases divided by population at risk over time, and prevalence is all cases. Try to understand the wordings. New cases, here all cases, divided by population at a specific time. This is the basic difference, and this is the definition which you can use, you can write in your exam, not writing so much in sentences. Now the formula for incidence is new cases divided by population at risk into 1000. This is the incidence rate, and the prevalence rate is equal to existing cases divided by total population into 100. So incidence is always aimed for the rise in the cases, the new cases among the population at risk, but prevalence is a gross estimation. So it would be covering the total population mostly. So it is the existing cases divided by total population into 100. Now, this is the difference in one slide. Incidence, probability of developing the disease. Prevalence, probability of already having the disease. Numerator counts only new cases. Here prevalence, numerator counts both new and old cases. Incidence, it requires follow-up of individuals in a population to identify new cases. Prevalence doesn't require any follow-up because it is already existing. It is existing for a long time. It would be there. So we cannot follow up these patients. It will be there. We cannot take out all the diseases in one go. Now, in incidence, it doesn't depend upon the duration of illness because we are not going for the duration of disease, whether it is chronic, whether it is acute, whether it is subacute. But prevalence depends on the duration of the disease. That means long duration will eventually increase the prevalence of a disease. So if it is tuberculosis, definitely the prevalence will be more. But if it is something like COVID, so maybe it is new cases coming in crop. So it would be something which will be our incidence of COVID, something like that. Now, the preferred measure is incidence when we are studying cause and effect. While in prevalence, the preferred measure when we are estimating the burden of a chronic disease of an attribute like smoking, the prevalence of smoking among the young population. So this is something would be more towards the chronicity, burden of chronic disease. Now, I will be giving you examples now, which would be clearing all your doubts. Now take three examples in the clinical science. First is common cold. So the incidents, try to read the examples. During the winter season, a community of 1000 people reports 100 new cases of the common cold over a month. So the incidence rate here is 100 new cases per 1000 people per month. Now, the prevalence, if at a specific point in the time, 50 individuals in the same community have a cold, so the point prevalence is 50 cases per 1000 people. Clear? Now, coming to another example, which is diabetes mellitus. In the incidence, it's in a city with 5 lakh residents, 5,000 individuals are newly diagnosed with diabetes in a year. So the annual incidence rate is 1000 per 1 lakh people. 5,000 divided by 5 lakh, which comes to 1000 per 1 lakh people. Now, coming to the prevalence, if 20,000 residents are living with diabetes at the end of the same year, so the prevalence is 4%. That means 20,000 out of 5 lakh people. It comes to 4%. Now, the third example is COVID-19. So incidence would be a country records 10,000 new COVID-19 cases in a single day. Now this daily incidence helps to track the spread of the virus. We have all seen during the COVID pandemic time. So like how every day the news was like coming that this is the the record case in a single day in a country or in a region. Now, in prevalence, if there are 50,000 active COVID-19 cases on that day, the prevalence indicates the current burden on the healthcare system. This is the example related to incidence and prevalence. Now, is there any relationship between incidence and prevalence? Prevalence is influenced by both the incidence of the disease and the duration for which the individuals remain affected. So they are interrelated. It's not like incidence going in one line and prevalence going in the other line. Now, this is a very important line. Try to understand. A disease with high incidence but short duration, like common cold, may have a low prevalence, while a disease with low incidence but longer duration, like diabetes, can have a high prevalence. I think it is clear. Now, the example is TB. Now, in a region, 50 new cases are reported for 1 lakh people annually. This is the incidence, but prevalence would be due to prolonged treatment duration. There are 200 existing TB cases per 1 lakh people at any given time. So for tuberculosis, so the incidence would be low, that new cases would be less, but prevalence would be high because the treatment duration is longer. So definitely patients will take more time to get cure of the tuberculosis. Now, understanding both incidence and prevalence is crucial for the public health planning, resource allocation, and implementing effective disease control strategy. Now, this is all about the first question, incidence and prevalence, which was asked in many of the critical care training exams like DRNB, DAM, as well as in one of the highly, like we can say, the practical exams and Viva exams of various other exams. Now, the second question which I would be discussing is null hypothesis. Now, what do you mean by hypothesis? Let's start with the hypothesis. Now, hypothesis is a tentative statement or explanation that proposes a possible relationship between variables, and to just make it standardized and validated, this needs to be subjected to testing and verification. Clear? So this is the meaning of hypothesis. We will be postulating many hypotheses, but the hypothesis is actually true. Hypothesis is actually justified. Hypothesis is actually applicable to our own clinical problems. That needs that these hypotheses need to be subjected to the testing and verification. Now, the overview of the hypothesis. A hypothesis is a testable prediction that seeks to explain a phenomenon or make a statement about the relationship between variables. Now, for any hypothesis, the prediction has to be formulated based on our prior knowledge, our observation over due course of time, clinical experience, and many theories that are there. Now, hypothesis is the first starting point for scientific investigation of any sort, and their validity is assessed through empirical evidence. So this is something which is the starting point of all research, all the the theories, postulations. Now, in the hypothesis, there are two examples. The types of hypothesis, if the examiner would be asking, it has null hypothesis, which is very important, and there is another one, alternative hypothesis. Now you need to understand what is null hypothesis and what is alternative hypothesis. Null hypothesis is, it's a statement that suggests there is no significant correlation or effect between the variables. Clear? Make it very clear that if X and Y are the two variables, they have no relationship between them. So that is null hypothesis. Alternative hypothesis is a statement that proposes a specific relationship or effect between the variables. If it is X and Y, so definitely alternative hypothesis is that they have some relationship. So that means when we are trying to go for alternative hypothesis, actually we are trying to challenge the null hypothesis, because null hypothesis doesn't believe in any relationship. Try to make it as simple as that. So it will be completely very bland in the emotional front, and it doesn't have any say on the is there any relationship or not, but rather it would say that there is no relationship. Now, in the hypothesis testing, it would be null hypothesis, which is the nomenclature is HO and or H0. Alternative hypothesis is H1. Now here in this region, this is the curve, the probability curve, epidemiology curve. In this null hypothesis is accepted. That means there is no relationship, but there would be also cases or theories which would be also rejecting this null hypothesis, and they will be trying to prove the alternative hypothesis, and we need to understand that. Now, what is the importance or what is the significance of null hypothesis in medical research? In medical research, particularly with critical care, the null hypothesis or H0 serves as a foundational concept in statistical hypothesis testing. In your exam, you have to write at least the overview, the definition. Then I will be also telling about the key components, then the strategies, then the examples, and then final implication. So you need to always have a structure when you are getting a short note or a long note, something like that. Now, the null hypothesis posits that there is no effect or no difference between the groups or the variable under investigation, as I have already told. And it suggests also, if at all somebody is trying to find out or figure out some or other relationship or any differences among the two variables, it is due to only random chance than a true effect. So these wordings you need to remember so that you can write in your exam. So it suggests if any observed differences are there, this is due to random chance rather than a true effect. Now, understanding null hypothesis in a better way. Now, the null hypothesis is the statement that states we all till now understood that there is no relationship between the two variables, and they feel that this is something they would be starting to do with the research. That means null means nothing. Simply remember NULL, nothing. Null is nothing, which defines that no relationship is present between the variables. Now, I am giving you one example. Consider the statement that says increase in the number of cancer patients is not due to increase in the pollution level. Now, in that case, it will be said there is no relationship between the two variables, that is the pollution level and the cancer patients number. So we are actually depicting the null hypothesis that there is no relationship. Cancer patients are due to their own problems and pollution is in the other hand. So there is no relationship between the two things. Now, the null hypothesis is typically the opposite of what a researcher predicts or expects. So if I am the researcher to find or I am interested to explore the relationship between the pollution level and the cancer patient, I will be starting with the null hypothesis, which has been written in the red color. Now, this null hypothesis is tested, and as a researcher, I would be trying to prove that this null hypothesis is rejected or it doesn't have any valid reason to be believed by many people. So that means researcher would be always trying to reject the null hypothesis. Now, the null hypothesis is believed to be true unless it is proved false by the researchers like me by finding evidence against it. As all the tests are done on the basis of null hypothesis, in the end, I can get two results. Is my null hypothesis is now getting rejected, or no, it is not rejected? That means there is no relationship between pollution level and number of cancer patients. Now, there are three key aspects of the null hypothesis. Purpose is null hypothesis provide a baseline for the comparison. We need to find a baseline, cancer, pollution, and that would be allowing the researchers like me to test the validity of my assumption. So if I am thinking something in my mind that yes, I need to do a research on these two variables, whether there is any relationship, whether doing this maneuver, doing this intervention, starting this treatment will be having any effect on the treatment or the recovery of this disease, then definitely I need to have a null hypothesis in my mind. Now the formulation, it is typically expressed as HO. It asserts that there is no relation. O means there is no relation. Null means there is nothing. So there is no association between variables or no difference between the groups. Now, the testing is through the statistical analysis. Researchers determine whether to reject or fail to reject the null hypothesis based on the probability value. Here comes the p value of observing the data if the H0 were true or the null hypothesis is true. Now, how to interpret the null hypothesis? Rejecting HO or failing to reject HO. The terminologies are like this. Rejecting means indicate sufficient evidence to support the alternative hypothesis that there is significant relationship or effect or difference exists. In our case, what I have given you the example, pollution level and cancer. If I am rejecting null hypothesis, then I am going for H1, which is the alternative hypothesis. And the alternative hypothesis is that increase in the pollution will be definitely having increase in the cancer level or the patients, the new onset of cancers. Clear? Now, failing to reject the null hypothesis, that means I have insufficient evidence to support alternative hypothesis. That means the null hypothesis stands true and it doesn't prove that actually the null hypothesis is like, no, there is no relationship and insufficient evidence to support the alternative hypothesis here. Now, examples in critical care. I am giving you examples that would be again clearing your doubts. Effectiveness, where you can use null hypothesis in our clinical practice, in our critical care practice. Now, effectiveness of a new drug. The scenario is evaluating whether a new medication XYZ reduces the mortality in patients with septic shock compared to a placebo. So many drugs we have seen in last maybe couple of years, which have been tried and tested, whether that has any effect on the recovery or the vasopressor recovery or the free days or like no organ free days, organ failure free days, something like that. Now, here the null hypothesis is the new drug has no effect on the mortality rate compared to the placebo. Clear? Now, in interpretation, if statistical analysis yields a p-value less than the chosen, which is a significance level of 0.05, we all know. Now, this null hypothesis is rejected. That means this drug has a significant effect on the mortality. So that's why whenever we analyze any article, we always try to find the p-value. P-value less than 0.05. That means, can we take it little bit seriously? I will not say that any drug p-value less than 0.05 will be having gross impact on the mortality, but as per this null hypothesis and alternative hypothesis, it has a stand now to be considered for further like the discussion as well as research. Now the second point here, ventilation strategies in ARDS scenario, comparing low tidal volume ventilation with the traditional ventilation method. If we will be starting with our ARDS net trial, which was been like many years back, so they have taken null hypothesis or H0 as low tidal volume doesn't differ from the traditional method in improving patient outcome. So that was their first hypothesis. Now, the interpretation, a low p-value would lead to rejecting this null hypothesis. That means low tidal volume has significant impact on the patient outcome. And that has actually been true in our ARDS net trial. Now, the third one, corticosteroids in septic shock. Whether corticosteroid administration having any duration effect on the duration of vasopressor dependency in septic shock patients. We have read so many articles based on this hypothesis. Now here the null hypothesis would be corticosteroids have no effect on the duration of vasopressor use compared with no corticosteroid treatment. And the interpretation, if your p-value would be less than equal to 0.05, this null hypothesis is rejected. That means corticosteroids influence the vasopressor duration. Now, what are the consideration in critical care research? Then comes the concept of type 1 error and type 2 error here. Now, what is type 1 error? Type 1 error is false positive. That means you are actually rejecting your null hypothesis, that is incorrectly, when it is actually true, leading to assumption of an effect that doesn't exist. Are you getting it? So you are trying to prove that yes, there is no relationship between the X and Y, the corticosteroids and the vasopressor, the free days. But actually there is no effect or there is no relationship. So that means you are going for a false positive test. That is type 1 error. Now, type 2 error, which is false negative. That means you are actually failing to reject this null hypothesis when it's actually false. That means you are missing a real effect. So there is a relationship, but you are not able to notice it or bring to the public, bring to the the final discussion part. This is type 2 error or false negative. Negative, but it is false. Now here comes the p-value. P-value less than the predetermined alpha level, which is commonly 0.05, that indicates statistical significance, warranting rejection of your HO or null hypothesis. Now, if you are not clearly understanding this type 1 error, type 2 error, p-value significance, and you are applying in the null hypothesis in a wrong way, so the interpretation of the study results are biased and they are not very accurate to guide you evidence-based clinical practice. Clear? Now, to err is human. So what are the type 1 and type 2 errors? Why these errors came to picture of biostatistics, or why the biostatisticians are so clean on understanding that is the type 1 and type 2 error? I am trying to give you a very good description. As much as researchers, journals, newspapers might like to think otherwise, statistics is not, definitely not a foolproof science. Nobody can say that this drug is going to help you in 100% time. So statistics is a game of probability, and we can never know of certain whether our conclusions, statistical conclusions, are correct. So that's why every article you have to take it with a pinch of salt. Now, whenever there is uncertainty, what happens? There is the possibility of making an error. And in statistics, these two types of statistical conclusion errors are when you are trying to test the hypothesis, that is type 1 error, type 2 error. This is again a very important question for your exam. So try to understand by this intro. Type 1 error occurs when you are incorrectly rejecting a true null hypothesis. That means positive you are making, but that is actually false. Clear? Now, a shorthand way to remember just what the heck that means is type 1 error is false positive. Type 1 false positive. Say you did a study comparing happiness level. I am not giving you any medical example right now. Happiness level between the people. You have given poppy to hold, and then you are assessing whether looking at the poppy you are becoming more happy, or like there is no difference. So poppy makes you happier or not. So that is the study. Now your null hypothesis should be there. There is no statistical significant difference in the happiness level between those who held and those who looked at a poppy. If you are actually holding the poppy, it is actually helping you or making you more happier or not. Now this is something little bit more descriptive, but try to understand it, because this is something you need to understand, otherwise you cannot mug up these things. Now suppose there is no real difference in happiness between the groups, which I have tried to say that people are actually just as happy when holding a puppy or looking at once. If your statistical test result is actually significant, you would have then committed a type 1 error. That means you are making it positive, but there is actually no difference. I am as happy as before also and now also, just looking at the puppy rather than holding. It may bite me. Okay. Now, this null hypothesis is actually true. In other words, you found a significant result merely due to chance. Now, the flip side of this issue is committing a type 2 error. Now that means failing to reject a false null hypothesis. That would be false negative. You are trying to find that there is no relationship between looking at or holding, but there is a relationship which you are unable to find or unable to trace. Using our poppy example, suppose you found that there was no statistical significant difference between your groups, but in reality, people who hold poppies are much happier. So this is the difference between type 1 and type 2 error, or false positive and false negative, whatever you are actually doing. Now, this screen slide will be trying to clear your all doubts. Don't go with all my sentences. Type 1, this doctor is asking this old gentleman, you are pregnant. So that means you know that this person cannot be pregnant. So that means you are making positive, but it is actually false positive. Now, type 2 error is negative. She is telling this lady who is obviously looking like a pregnant lady that you are not pregnant. But definitely she is pregnant. That means false negative. Negative, but it is false negative. Clear? So this is the difference between type 1 error and type 2 error. Now, this type 1 error is also, you can give the nomenclature as alpha error. A type 1 error occurs when a true null hypothesis is incorrectly rejected, leading to a false positive result, which we do not want. This means concluding that an effect or difference exists when it actually doesn't. Clear? Now, the probability of committing a type 1 error is denoted by alpha, which is normally set at 0.05, indicating 5% of risk of a false positive find. This is acceptable. 5%. This is something in any study, statistical study, they can take it. Now, medical example I am trying to give you. I'm trying to make it little bit more interesting by giving that the drug has no effect on the mortality compared to the standard treatment is the null hypothesis. Type 1 error is concluding that this new drug significantly reduces mortality when in reality it doesn't. So this is something positive, but it is not actually positive. It is actually negative, but we are falsely labeled that this drug is creating magic in the septic shock management. So definitely, if we are going to adopt this ineffective treatment, I am trying to do more harm to my patient by exposing my patient to unnecessary risk and diverting resources from more effective therapy. That means I am trying to give more importance to this unnecessary therapy, which may create more problem in terms of the recovery. Now, coming to the type 2 error, which is the beta error. Type 2 error occurs when a false null hypothesis is not rejected, resulting in a false negative. That same thing like the pregnant lady. This means failing to detect a true effect or difference. This is again very dangerous. The probability of committing a type 2 error is denoted by beta, with 1 minus beta representing, again this is another question, power of the test, which reflects that this test's ability to detect an actual effect. The medical example. Now, if the example of low tidal volume ventilation strategy. I know finally at the end of the study that low tidal volume has definitely helped to ventilate the patients with ARDS. Null hypothesis says no relationship. If I am going for more towards type 2 error, I am not getting any clear-cut evidence that low tidal volume ventilation is actually improving patient outcome, which is not very good thing. My study has done error in not able to get the correct relationship between low tidal volume ventilation and patient recovery. So this oversight could prevent the implementation of a beneficial intervention, potentially leading to higher morbidity and mortality among ARDS patients. Just think, if the ARDS net trial would have been a fail, and we still what until now also we were using the normal conventional mode of ventilation, the tidal volume. So definitely that was not a very good expected from the scientist at that time. Now, the chances of committing these two type of errors are inversely proportional. Again, very important here. Type 1 error, type 2 error. So everybody would be saying that I would be making my type 1 error list, type 2 error also list. Can it be possible? No. Decreasing type 1 error rate increases slightly type 2 error and vice versa. Now, your risk of committing type 1 error is represented by your alpha label, p value, which all we know that alpha value of 0.05. Okay. Now, to decrease your chance of committing type 1 error, what you have to do? Simply make your alpha more stringent. Maybe not 0.05. I would go for 0.03, 0.01. That means I am unable to right now, going for a little bit of false positive also. Now, chances of committing type 2 error are related to your the analysis statistical power. Now, to reduce your chance of committing type 2 error, how you are going to increase your analysis power? By either increase your sample size or slightly relaxing your alpha level. So in that case, maybe your false negative would be less. Now, the balancing type 1 and type 2 error, this is very critical in the critical care research. Reducing alpha, setting a more stringent significance level, I have already told, alpha around 0.01, but it would be increasing the risk of type 2 error, potentially overlooking the genuine effects. Now, reducing beta, which is the type 2 error rate, this would be enhancing the study power by increasing the sample size or the effect size detection capability that I have told. But the flip side about reducing the beta will be requiring more resources. You will be using this for prolonged time, and that would be something researchers must carefully design the study, that both the types of errors would be balanced or minimized. And finally, the critical care intervention would be effective and safe. So whenever in your exam, maybe in your theory or practical, any examiner would be asking, they would be trying to get the idea that whether you have actually understood the concept of type 1 and type 2. No study can boast that I have my the least type 1 and type 2 error. You have to have type 1 and type 2 error, but yes, the target should be minimal. Now the clinical implications of understanding and mitigating type 1 and type 2 errors are vital in critical care to prevent harm. First one is harm. Do no harm or less harm. Avoid implementing ineffective or harmful treatments based on the false positive results. Some drug for septic shock. If you are not going to reduce this false positive, you are actually giving unnecessarily drugs for your septic shock patients. Ensure, second point is ensure efficacy. Recognize and adopt beneficial interventions, preventing missed opportunity due to false negative. This is related to type 2 error. If you are not getting the idea that low tidal volume ventilation has a better role in managing this ARDS patients, you are actually missing the opportunity to adopt beneficial intervention. And finally, optimizing the resource allocation. That means if you know the proper therapy, you will be channelizing all your resources to that intervention with proven efficacy, enhancing the patient outcome and healthcare efficiency. So this is something very important for evidence practice and also contributing for our medical literature advancement of the critical care medicine. Now, in one the table, if you just remember, true null, false null, reject null, accept null. I'm just going. Then the true null, here it comes type 1 error, alpha error, false positive. Then here accept and false null, type 2 error, beta problem and false negative. Now here you get true negative and true positive. This is the probability curve. Just for your understanding, this is the null hypothesis, this is the alternative hypothesis, this is the critical value, this is the beta error, this is the alpha error, false positive, false negative, and this is the true positive, true negative. So if you remember, you understood this concept, you can easily draw this picture. This picture can say 1,000 words. Now after this, I am going for one question that is very important, that came in multiple times in your exam. So I will be giving a short note of a power of a study. Now, power of a study, understand the power of a study, a critical aspect of evidence medicine. If a question comes this, I am just explaining you how to answer it. What is the power of a study? Definition: the probability that a study will detect a true effect. That means difference or association if it exists. The formula for power is 1 minus beta, where beta is the probability of type 2 error. Now, what is the standard goal? Power has to be minimum 80%. This is the commonly used threshold. This is the first point. Now, why is power important in critical care research? Because it prevents false negatives, guides the sample size, increases the validity of our study conclusions, and key for the rare events, especially in critical care where rare outcomes are actually studied. This is the importance of power. Now, what are the factors affecting power is the third point. Sample size, large sample size, high power. Large true difference, high power. Low alpha, low power. Less variability, high power. And if you are adopting randomization, blinding, that would be improving your power. So study design has also effect on the power. Now the fifth point is how to apply power in critical care study. We can apply power in critical care studies in the design phase. On the basis of power analysis, we can decide the sample size, the n number. Then in the interpreting the results, if we get a study and we are doing the critical appraisal, if a study has enough power, definitely that would be detecting clinically significant effects. Systematic reviews, be cautious about underpower study. Don't take it very seriously. Maybe the meta-analysis would be published, but if it is powered, definitely it is not going to be more interesting or impressive to me. Now, what are the challenges with study power? Underpower studies may fail to detect true effect. Overpower studies may detect clinically insignificant differences that would pick up, like no small, insignificant things also. And the practical limitation, financial and ethical constraints in increasing the sample size. Everybody knows that if you have n number enough, then your power of the study would be better. But how no big you will be recruiting your n number, so that is again a question mark. That depends on so many things, ethical, financial, whether it is justified or not, so many things. And finally, power is 100 minus power is equal to beta. So 90% if it is no power of the study, so 10% would be the beta error, or the error of the second kind, false negative. Now comes the third part of my the topic, risk assessment overview. Risk measures are divided into relative risk, absolute risk reduction, ARR, odds ratio, hazard ratio. So rather I would say engagement to make yourself easier, RRR. This RRR movie everybody knows. So this is something rise, roar, and the revolt. Now, what is risk assessment in biostatistics? It involves quantifying the likelihood of adverse health outcomes by analyzing various risk factors. Because when you are using so many things, medications, interventions, procedures, therapies, definitely we need to also have a robust risk assessment. Now, in critical care, this is again very vital to identify patients at elevated risk for complications. Should I go for this advanced therapy or high risk therapy in already suffering patient where there is hardly any chance of error? So definitely that would be guiding our clinical decision making and resource allocation. Now, what are the key components of risk assessment? First of all, you have to identify the risk factor, determining patient characteristics or exposures that would be increasing the likelihood of the adverse outcome. Second one, once you are identifying the risk factors, you have to quantify the risk, utilizing the statistical measures to estimate the strength of association between risk factor and outcome. And the third thing would be again risk stratification, quantification, then stratification, classifying patients into different risk categories to tailor the interventions appropriately. Now, what are the statistical measures in risk assessment? Relative risk, odds ratio, hazard ratio. Relative risk is comparing probability of an event occurring in the exposed group to the unexposed group. I am giving you many examples in the upcoming slides. Now the odds ratio is representing the odds of an event. The event, what is the chance of the occurrence of that disease or event in the exposed group relative to the unexposed group, commonly used in the case control study. So case control studies normally have odds ratio. Now the hazards ratio is often used in the survival analysis. You must have seen in many of the systematic review analysis, meta-analysis, hazards ratio, HR. This assesses the rate at which an event occurs over time between the two groups. Clear? Now the medical examples. I am giving you medical examples. Predicting mortality in your ICU. Assessing risk of hospital acquired infections. Evaluating the risk of AKI in ARDS patients. So these are the examples where all this risk assessment is having very significant importance. Predicting, assessing and evaluating, and that has importance in the application phase, process and outcome. So the hospital, the clinicians would be definitely going to improve these 3 points to go for all these risk analysis in their different intervention practice. Now, methodological considerations, definitely if you are thinking about your risk assessment, you have to go for study design in a proper way, whether it is cohort study, case control study, to accurately assess the risk factor. Point number one. You need to find, identify, adjust the confounding variables that would be destructing the true association between risk factor and outcomes. That is point number two. Now, the third methodological consideration that you can do is to ensure that these risk assessment models, the scoring systems, the prediction models are actually accurate and they are generalizable in the different patient populations. Then only your risk assessment methodology is doing good for your clinical practice. Now, what are the clinical implication of this risk assessment analysis? Effective risk assessment in critical care enables personalized medicine, preventive strategies, and resource allocation. If you know that this is one area, if I am actually diverting my resources, my knowledge, my talent, then the outcome will be great in terms of recovery, in terms of the better the health outcome, the patient outcome, and ultimately the overall the medicine will be more effective in terms of the efficacy as well as safety. Now, let's go one by one as the definition. Example: relative risk, probability of an event occurring in the exposed group to the probability in the non-exposed group. Example: if the risk of an adverse event is 10% in the treatment group, 5% in the control group, then what is the relative risk? 10 by 5 is equal to 2. That means in the treatment group, the risk is double because the ratio is 2. But in the control group, it is 1. Then in the treatment group, it is 2. So double risk of getting the complications or the disease. Now, the example is risk of ventilator associated pneumonia. Clear? So the formula RR is risk in exposed group by risk in the non-exposed group. Now, coming to the absolute risk, AR. Probability of an event occurring in a specific group. If 2 out of 100% develop a condition, the absolute risk is 2 by 100. It is absolute in a number. You have to just get the idea how many patients, how many person would be developing this condition. 2%. But relative, comparing exposed versus non-exposed. And the example is mortality reduction from sepsis intervention. All the patients have been given this therapy and you are comparing how many patients would be having better mortality. This is absolute reduction. Now, AR is number of events divided by total population. Now, ARR, this is absolute difference in risk between the two groups. If 20% of untreated patients experience an event and only 10% of treated patients do, then the absolute reduction is 20 minus 10, that is 10%. Clear? Formula is absolute the risk of the control group minus the treatment group. You have to calculate. Now, then comes the odds ratio, which is OR. Definition is measure of association between an exposure and an outcome. And this would be comparing the odds of developing, having the event in one group to the odds in the other. So the formula is A divided by B whole divided by C divided by D. So it would be coming AC by BD. Now I will be giving you example. Odds of survival in patient receiving early CRRT. Now the example is 4 out of 10 patients in a treatment group survive and 2 out of 10 in a control group survive. That can happen in any study where you are using early versus late CRRT group. and you are using the control group where standard therapy you are using. Now, in the CRRT group where you are using early, you are getting 10 out of 10 patients, 4 patients recovered. And in the other standard modality therapy, standard of care therapy, you are getting 2 recoveries out of 10. So your odds ratio is 4 divided by 6 because the patients, remaining patients are 6. Now, 2 divided by 8. That means 4 divided by 6 whole divided by 2 divided by 8 is equal to 2.67 is your odds ratio. Now the story doesn't end here. We have to go to the next level where we can get the hazard ratio or HR. Now, what is the definition? Ratio of hazards in two groups over time. And hazard ratio is a measure of an effect of an intervention or an outcome of interest over time. And this is mostly used in time to event analysis or survival analysis. When we want to know how long it takes for a particular event to occur, hazard ratio. And this rate of events in one group to compare to the other group is often used in survival analysis. Remember this word, survival analysis, you have to go for hazard ratio. Survive, hazard. So you have to correlate these two things. Now, the outcome could be an adverse or negative outcome, like a patient has died in your ICU, patient has died post-operatively, or there has been a relapse in the infection rate. So this is something adverse or negative outcome, or a positive outcome, which can be curing, discharge, conceiving, healing, disease-free interval, something like that. Now, hazard ratio, the most important application is survival analysis in critical care studies. And the examples are comparing survival times in ECMO versus non-ECMO. You are putting one patient in ECMO, you are not putting that patient on ECMO. So how actually the patient survival is actually affected. Example, if a patient on a new drug are 30% less likely to die than those on a standard drug. That means the hazard ratio is 0.7. Clear? Because 30% is less likely, so hazard ratio is 0.7. Now hazard rate in the treatment group divided by hazard rate in the control group is the hazard ratio, because it's a ratio, so it would be in the point. Now interpretation of the hazard ratio, because hazard ratio is a ratio, that's why hazard ratio can be 0.5, hazard ratio can be 1 also, hazard ratio can be 2 also, less than 1, more than 1, it can be up 2 options or equal to 1. Now hazard ratio 0.5 at any particular time, what does it mean? Half as many patients in the treatment group are actually experiencing an event compared to the control group. Hazard ratio 1 at any particular time, event rates are actually same in both the groups, whether you are using or whether you are not using. And hazard rate is equal to 2. That means twice as many patients in the treatment group are actually experiencing more event compared to the control group. So this is something dangerous. Clear? Now, confidence interval. I know my next speaker would be talking about confidence interval. I'm not going into detail, but if your confidence interval is including the 1, then the hazard ratio is not significant. I'm not going into detail because that is something a completely separate question which need to be discussed in detail. Now, what is the difference or relationship between hazard ratio versus risk ratio? Hazard ratio is frequently interpreted as a risk ratio or relative ratio, but they are not technically the same. Now keep in mind, one of the basic difference between risk ratio and hazard ratio is risk ratio doesn't care about timing of the event, but only the occurrence of the event by the end of the study, whether that has occurred or not occurred. That means the total number of events by end of the study period. But hazard ratio takes account of not only the total number of events, but also timing of each event, when actually it has happened. The hazards has actually occurred, at what time interval, and how frequently. That also is part of the hazard ratio assessment. So that's why hazard ratio is a better surrogate than the risk ratio. Now the last part of my talk is validity. Now, what is the definition of a validity and why it is important in statistics? Validity in statistics refers to how accurately a test, a measurement, or a research study measures what it intends to measure. That means we are boasting to to be the number one, but how we are actually number one, our work has to be represent. So it is essentially about the truthfulness and accuracy of the research conclusion. You try to understand with simple languages so that you can extrapolate, write in your own words in the exam. Now, what are the types of validity? It can be internal validity, external validity, construct validity, content validity, face validity, statistical conclusion validity. So these terminologies are very important. If you remember this terminology, you can write 2 lines about this individual validity. Now, this is one the float chart, or I would say algorithm. Validity, internet validity, external validity. In internal validity, you go down content validity, face validity, construct validity. In construct validity, it is convergent validity, discriminant validity. Now, coming to the external validity, it would be population validity, ecological validity, test validity has again criteria validity, predictive validity, concurrent validity. Don't worry, I'm trying to explain in very simple language. What do you by internal validity? It measures how well a study establishes a cause and an effect relationship. And it would be focusing whether the changes in the dependent variable are actually caused by changes in the independent variable. And this would be threatened if you are not going for good the selection process, your history, maturation, testing, and instrumentation issue. So your internal validity will be affected. So there are certain limitations of the internal validity that you need to keep it watch. You should be having least selection bias in your study. And what is the practical application? It would be like I am giving you example, testing a new teaching method. And the control group is traditional teaching, and experimental group is I am giving you example webinars, new teaching method. Previously it was not there. Now the controls needed the same teacher for both the groups, the similar time per day of the classes, random assignment of students, people who don't like to go to school, they will be definitely liking the online classes, but that will not be proper selection process of the students. And controlling for the pre-existing knowledge. If the candidates who are very smart, so in the webinars like you all, so you will be immediately grasping the the whatever I am telling. But the candidate has never gone to school or college or understood the statistics. If I am trying to explain them in the webinar, maybe there would be a bias of the selection process. So this is internal validity. So I need to go for internal validity to know whether online classes are better than the offline classes. Now, next one is the external validity. This is something refers to how generalizable the findings are to other situations, populations, or the settings. That means, can I determine that my results can be applied beyond the specific study context? And this would be something affected by sample characteristic, your setting of the study, and how when you are doing the research. Can I extrapolate my study to other settings also? Now I am giving you again a practical example, drug trial example. I am trying to test a new medication only on young males in the urban area. Clear? Now the result may not be valid for the women, elderly people, rural population. That means my external validity is not good. Though I have done a very good justice to my study, but I need to include diverse demographic groups and settings to make my study more valid externally. Now, the third one is construct validity. It measures how well a test measures the theoretical construct it claims to measure. I am trying to have a very good theory in my mind, but is my operational definition or whatever I am getting the results accurately reflect the concepts that I have actually thought about initially? And this would be including two validity. construct validity, convergent validity related to the measures correlating, and discriminant validity, that means unrelated measures that actually they don't correlate. Convergent means converging whatever related measures, discriminant would be unrelated. Now I am again giving you one example, measuring the intelligence. I am trying to measure the IQ level based on the multiple aspects. If a student is good in the verbal reasoning, mathematical ability, pattern recognition, and spatial awareness, I should be also correlating with the academic performance and also problem solving ability if given a like a scenario instantly. But my construct validity will not be good if I am trying to correlate with physical strength of the student and also musical taste of that student, because that would be something I am not trying to get. I'm trying to get the IQ level based on this verbal, mathematical pattern and spatial awareness. Now, content validity, the fourth one, evaluating whether a test covers all aspects of the construct being measured. That means all relevant components I'm actually trying to validate, and that is normally through expert review. Content validity, I'm actually trying to share with someone who is a key leader in this field. So that is content validity. And the example again I am trying to give you. Mathematics test example. For a sixth grade mathematics test, the idea initially was to cover all topics in curriculum, questions at appropriately sixth grade difficulty level, and I have to mix and match easy, medium, and hard question. But the content validity has to be verified by experts who are actually math teachers, curriculum specialists, and also who are doing research in the education. So they would be validating my content to give the certificate that yes, the content validity is good. Face validity, the fifth one, the extent to which a test appears to measure what it claims to measure. This is again something like we normally watch so many ads in the TV, in the our mobile, it is coming. But how actually it is proving to be what they claim to be, that is the face validity. And this is the least rigorous form of validity, only important for, as I have told, buy-in and engagement, something like that. The example is job skill assessment. Everybody will be trying to say I can do everything what you do, what you give me. I am ready to give the best of my ability, but I need to find proper position for my secretary based on the typing test, email writing, my calendar and my timetable management, and phone etiquettes. So this is something I need to have in my mind to actually find the face validity. If somebody has written in his or her CV that I can do n number of things, but if he or she is unable to do these four things, that means the face validity is failed. Now the statistical conclusion validity, again, the all the statistical test that I want to know: sample size, statistical power, appropriate statistical test, and the reliability of the measures. And the new product should be of adequate size. What are the test, ANOVA test? What is the significance label, typically p value less than 0.05, and what are the measurement tools I have actually used? That would be statistical conclusion valid. Now the key steps to ensure overall validity, last few slides, is planning phase, implementation phase, and analysis phase. You should be having clear research questions, appropriate methodology, and well-defined variables to have a proper validity of your research. Then you have to implement it with strict protocol adherence, quality data collection, and proper documentation. Then the third page is analysis, how you are using statistical methods, how careful you are in interpreting, and how you are acknowledging the limitations at the end. Everybody must have seen any good study, they will be citing the limitations of their study at the end. So these are something to just ensure overall validity of a good research. Now, common validity threats, I have already explained these things in between, all the validities: selection bias, measurement error, and environmental factors. whether you are actually giving proper documentation, data collection, instrumentation is good or not, dropping out you are accounted or not, random sampling you have done or not, and document selection criteria you have followed or not. Now, Darshan, I have few questions just for the sake of quiz questions or to check the understanding. I am done with my presentation. It's just 1 hour, 5 minutes or so. So do you think I should be sharing these questions, or at the end we can share them all these questions to try?
I think so. It should be okay, sir. 5 minutes. Let them see the
Yeah,
questions, sir. They
yeah,
can
yeah.
answer in
Okay.
the chat box. Yeah.
Yeah. Okay. Okay. I'll be quick. I'll be just showing the questions and the answers. Now,
Sure.
this is question number one related to incidence and prevalence. What I have taught you. A hospital reported 50 new cases of sepsis in the ICU during past month. The total number of patients in the ICU was 500, and 200 of these were already diagnosed with sepsis. Calculate the incidence rate, calculate the prevalence rate. Can anybody tell? Immediately post in the chat box. Darshan, you check. I will be showing the answers only because otherwise it will take a lot of time. Yeah. Okay. So the incidence rate is here. New cases by total population at risk. So 50 divided by 500 minus 200. 16.67%. How many of them have been correct? Darshan, can you tell me?
Uh, uh, few only two answers I've got, sir, and most of them have written it quite similar but not correct, not accurate. Probably
Okay.
a quick
Okay.
calculation, sir. Yeah.
Yeah, exactly. So your mathematics has to be good, and we don't want to check your mathematics knowledge. So, and the prevalence here again 500, 50 plus 200. That means new plus existing. 50 new, 200 existing. So 250 divided by 500 into 100. So 50%. So in your MCQs, this can come in the table viva. They can show you in the single line question, and they can expect the answer from you, and they can give you a scenario in your theory also. Okay. So second question related to null hypothesis. Scenario is a new drug is being tested for reducing mortality in critically ill patients. Now the null hypothesis states that the drug has no effect on the mortality compared to the standard treatment. Now question is, if the p value is obtained is 0.03, what does it imply about the null hypothesis at a significance level of 0.05? Now should the null hypothesis be rejected or not? Why? Anyone? I have given almost 10 examples to explain null hypothesis and the p-value. Okay, so I'm sharing the answer. If the p-value is obtained 0.03 is less than the significance level, we reject the null hypothesis here. Okay, and now, yes, the null hypothesis should be rejected because the p-value indicates that there is a statistical significant effect of the new drug on mortality. I have already explained with the example. Clear? Now, alpha error and beta error. Third question. You are testing the effect of a new ventilation strategy on ICU mortality. Now, the study concludes no significant difference, but in reality, the new strategy does reduce the mortality. Now, what type of error does this represent? Explain. And how can the study be designed to reduce the likelihood of such an error? Thought provoking. Yeah. But I think there are a lot of answers coming in the chat box. So I could engage you and your mind has started to work. Maybe the errors done by you would be increasing, but don't worry. You should be able to answer the alpha error or beta error. Okay. Now this represents a beta error because the study failed to detect a true effect of the new strategy when it actually exists. That is false negative. So the result came as there is no significant no relationship with this new strategy. That means negative, but it is actually a false negative because it actually exists. Okay. Now, how can the study be designed to reduce this type 2 error? Increase the sample size, then improve the study power, use an appropriate effect size in the calculation, and ensure the study design minimizes the variability. Something like that. Okay. Now, the fourth question about the risk assessment. In a study of 200 ICU patients, 100 received drug A, 100 received drug B. After 30 days, 30 patients on the drug A survived, 20 patients on the drug B survived. Now calculate the risk, relative risk for the drug A versus drug B. Calculate the absolute risk reduction. And if the odds ratio is calculated as 1.5, interpret its meaning. Oh my God. I am trying to be a statistician somehow. Okay. Don't send me your hypothesis just to check your thesis. Okay. Anyone who has posted this in the chat box? The first one is very easy. The second one is also very easy. And the third one is extremely easy. I don't see the chat box numbers to be increasing. Okay. Now, the relative risk is risk in the drug A group divided by risk in the drug B group. So it is 30 by 100 divided by 20 divided by 100. So 0.3 divided by 0.2, 1.5. Clear? Now, absolute risk reduction 30 divided by 100 minus 20 divided by 100. This is risk in drug A group minus risk in drug B group. So 0.3 minus 0.2, 0.1, which is 10%. 10% is the ARR. Now, odds ratio calculated as 1.5 means the odds of survival with drug A are 1.5 times higher than with the drug B. Clear? Okay. Now, last one question or two questions. Hazard ratio. A study comparing two ventilation strategies for ARDS patients provide a hazard ratio of 0.75 for mortality with the new strategy compared to the standard. The answer came. Okay. Now, what does an hazard ratio of 0.75 mean in this context? If the confidence interval is 0.5 to 1.0, 1.20, what can you infer about statistical significance of the results? Anyone? First of all, what does hazard ratio of 0.75 mean? Okay. Now, hazard ratio of 0.75 indicates that the new ventilation strategy reduces the hazard of mortality by 25% compared to the standard strategy. Okay. Hazard ratio 1 means equal. Both the two therapies will be having equal effect. Now, 0.75 means it is less than 1. That means good. So they should be reducing the mortality by 25% less than the 1%, like 100%. So it would be 0.75. So 25%. Now, if the confidence interval for your hazard ratio is 0.5 to 1.20, what can you infer about statistical significance? Since the confidence interval includes 1, I have told you in the last slide, the results are not statistically significant. If your confidence interval is including 1, that means you are uncertain whether this new strategy truly reduces your mortality or not. Now, I'm not going into this validity. Yeah, there are questions, but yes, I think most of the things have been already discussed. The internal validity and the external validity, how you are going to discuss. So these are have been taken by from very high yield textbooks and journal articles, and some of them have been like derived from the recent studies relevant to the critical care. Thank you very much.